it is such a paternalistic view of advocacy. And
Yeah.
I've taken it a step further, and I think it's paternalistic ableism.
Yes.
You as a person living with a disability or a chronic health condition, you don't know what's best for you. I do. I know what's best for you. I'm your provider. Let me take care of you, instead of allowing them to take care of themselves, giving them the tools to take care of themselves.
Welcome to the Building the Noise podcast.
Ladies and gentlemen, welcome to the Building the Noise podcast. I'm Matt Teresco, and with me today, Brandon Macsata, the consummate advocate's advocate. Brandon I've known Brandon for, almost 11, 12 years now, it seems. We've worked together on our Elevate research. He is someone that I look to as a true expert, not just in advocacy, but in public policy. So Brandon, welcome to the show.
Matt, good to see you. Always good to build some noise with you.
That's right. Hey, and as you said, we're building the noise so that the patient community, the general public, whatever you consider yourself, at some point you're going to be a patient. Let's not wait until you are a patient to tackle some of the big issues that are facing the patient community today.
And what a novel concept, Matt, to actually try to invest and understand what the patient has to say, right?
You say that, and I know that you're saying it tongue in cheek, but oh my goodness, you've been in the advocacy space for how long, Brandon?
I've been doing this for 30 years.
30 years, and companies will constantly say, we're doing the right thing by the patients. We want to know what patients want. That's not really always the case, though, is it?
No, it's not.
Yeah.
And oftentimes it's so many other mitigating factors. And it's not the people doing the work. They're committed. They're the doers. They're the believers. They genuinely want to be engaged with patient advocacy organizations. It's all the layers that go above them that complicate that relationship. And what we as patient advocates have to do is figure out that maze and how to navigate it, because there are cracks in the armor, and you can get into the operational structure, so to speak, which leads to not only the funding. The funding is important because it pays the bills and keeps the lights on, but the relationships. Being able to reach out to a company and say, hey, I can't find data on XYZ. Well, what better place than the manufacturer, because they track everything, right? Do you know somebody in Congressman, John Doe's office? I would really like to, communicate with them. So it's the relationships that go along with that funding that really are what allow advocacy organizations to succeed.
Yeah, we're going to dive into those relationships at depth. As I said, I started the Elevate research 11 years ago. You were one of the loudest and first respondents when I started it back then, and have remained so. And you've taught me a lot about this advocacy space, and it's been a privilege to be on some of the boards of the organizations that you've run. What I've always loved about the way you've approached patient advocacy is not just, hey, the patient is who our focus is, but more so that, yes, we might be committed to this disease state and patients that have this disease, but there are other folks in other areas of healthcare that could benefit or should have a voice in this discussion. Tell me a little bit about how that mindset came about. And I guess truly you follow the Denver principles, right? Which is nothing about us without us. But I'd love to hear why you are such a innovator and leader, and you take this approach of building that boat and moat around patients.
Matt, I first started doing your surveys at the request of my late mentor, Bill Arnold. He spoke very highly of you and said, this is a survey. I think he had done it 1 year. He found it very intriguing. And ever since then, I started doing it. And I bring up Bill because one of the biggest lessons I learned from him was, when you do this work, you have to leave your personal politics at the door. The minute you allow your personal politics into play, it clouds your judgment. And that is important when you're dealing with political parties, because you may make an assumption that, well, that party is never going to care about this issue or never going to fund this issue, when indeed all you need to do is look at the historical record on just about any disease, and HIV is no different.
Yep.
Or it's a region of the country. You may say, oh, well, this isn't, they don't care about this issue in that region of the country, or whatever. And if the minute you do that, it clouds your judgment. So you have to be very open, and there are times you have to bite your lip, because you may really have a serious concern or issue with how a particular politician believes on one issue. But if it's on your issue and you align, that's what you have to focus on. Get it done, and then you can go back to having your animus toward them on the other issue, right?
Sure.
And I think for me, as someone who's living as a patient, I'm a long-term survivor living with HIV, almost pushing a quarter century, 25. I've been living with this.
That's just between us.
That's just between us. And you know this very well, I'm unapologetically pro-patient.
Yeah.
And it boggles my mind that we have, drug manufacturers trying to influence policy, hospitals trying to influence policy, PBMs now trying to influence policy, government agencies trying to influence policies, and all these people who are fighting over where the money goes. That money is being spent for one reason, for patients. And yet they're discounted on their participation, or there's certain restrictions put on their participation, or they look at it and say, oh, here comes the patient. All they're going to do is bitch and moan. Well, maybe you should listen to that bitch and moaning, because if you get through that, you're probably going to identify reasons why the system isn't working the way it's designed. And we know that is very common, whether it's a public program or a private insurance, doesn't matter. It's oftentimes does not work the way it's designed. So yes, I am very loud, which is, I love your podcast, Building the Noise. You know me, I'm loud when it gets to this, because I think without patients in their participation and their insight, policy falls flat.
Yep. I want to go back in your story and really get a sense for how you got into this. You noted that your diagnosis, but patients every day are faced with that challenge of, now what? So what got you into advocacy? What was it that made you say, you know what? Yes, I have this condition, but there's more to life than just this condition.
My first intro into patient advocacy was in a past life. I was the assistant administrator / marketing director of a 103-bed assisted living facility. So elder care became a very central part of my life. I lived, breathed, and sweated every single day. And when I saw how payment parameters were set up that were unfair to certain patient populations who were aging, when I looked at the lack of resources, when I looked at the fact that, and this is mind-blowing, that we're paying folks minimum wage to bathe, toilet, feed our mothers and fathers. And back then, not to date myself, to be in the 90s, late 90s, and minimum wage back then was what, $6 an hour?
Yeah, $5.25, $6.
Depending on which state you were in. Think about the profanity of that we're paying minimum wage people who are taking care of lives. Their lives are in their hands. So elder care was my intro to it. And then a few years later, I literally fell into a job that was focused on disability rights and disability advocacy.
Sure.
It was an organization that represented nonprofit community providers to supports and services for people living with developmental disabilities. And I fell in love with it, and got to meet some of the most amazing people living with disabilities who were leaders, thought leaders, movement leaders. They inspired me. They challenged me. John Kemp, who was, as a child, was one of the first poster children of Easter seals, became a dear friend, and he was a very central part of my life. Rebecca Coakley, who has been in all sorts of roles over the years, a little person, one of the most passionate people I ever met. Got introduced to her very early on, and so many others. And then boom, all of a sudden one day, I'm now a patient.
Mm.
I've been diagnosed with HIV, and I wasn't just diagnosed with HIV. I was diagnosed with full-blown AIDS.
Wow.
My immune system had just collapsed. And for me, I think one of the reasons why I accepted that diagnosis so easily was because of the people in my work world who had become my friends. And I'm like, if that person can live their life without arms and legs, or if that person can live life with the challenges of being height challenged, as
Yeah.
my little people friends like to say, then I can live with this condition. Especially at now, at that point there were medications on the
Sure.
market,
Yeah.
retrovirus. So, and then that is where it really became very personal for me, because now I'm living it. And then because it was personal, it made me really evaluate the way systems are set up, and they're truly set up to sideline patients. And that just was
Mm.
not acceptable for a little Italian boy who likes to run his mouth. He sees something he doesn't like.
Yep. So you talked about when you were diagnosed and how it was easier because you had people around you. What would you say to a newly diagnosed patient today that thinks this is it? This is I don't have any support system. I don't have folks with me. What do we tell them to do?
Live your life.
Hmm.
Um, and it. I don't want to make it dismiss it. I don't want
Yeah.
to make dismiss the seriousness of the condition. If you don't take care of yourself, this is a really bad thing to have.
Yeah.
But I say live your life because, if it means changing some lifestyle habits, change some lifestyle habits. But if it means, going to your doctor every month, every quarter, every 6 months, then go. And if there and I'm going to circle back to that, because I can already
Yeah.
see my flank being, people coming at me on my flank. How could you say something so
Sure.
broadly? And your medications. I mean, we know with HIV that if you're adherent,
Hmm.
meaning you take your medications pretty much when you're supposed to. We all make mistakes. We all
Yep.
have hiccups in life and whatever, but you don't have to take it every single day. But you should be in the 90th percentile when you're taking your meds. Your health, your life expectancy is the same as a person who's HIV negative, right? Um,
Yeah.
that wasn't the case back when this first reared its ugly head.
Sure.
People lived maybe a year. So, and I get there are challenges: transportation,
Hmm.
housing, stigma, you know, provider stigma. I mean,
Yeah.
no better place do you see provider stigma than young Black women going to, going to see something about their childbirth and
Yes.
maternity care.
Yep.
It is maternal health is probably one of the worst examples of provider stigma and
Yep.
discrimination. These poor women are dismissed left and right, but I think there are still things that you can do as an individual to live your life, and that's not to say it's going to be easy. It's
Yeah.
not going to say there aren't going to be times where you're like, wait, what? And I know what that feels like, and you know this story.
Sure.
At the time I was diagnosed, here I am working for a disability organization. I have insurance. I get my insurance the first month. I think I had like a $20 copay for my HIV meds. The next month I go to get my meds filled and they tell me the bill's $1,300. I'm like, what are you talking about? I have insurance. They run the insurance again. They're like, nope, $1,300. Lo and behold, I had a pharmacy rider attached to my health plan, and the annual out of pocket maximum was $1,500 a year.
Oh,
Okay, I blew through that in the first month.
yeah.
That's why I imported drugs that I didn't know from Canada, that I didn't know whether they were HIV drugs or if they were counterfeit. I just knew I could
Yeah.
get them for $300. So I know what it's, personally know what it's like when you confront a barrier and you're like, oh my
Yeah.
God. That's why I went on the AIDS drug assistance program. That's why I'm
Hmm.
so passionate about protecting and enhancing AIDS drug assistance programs. Because that was, for me, for 6 months of my life, was a lifeline until my insurance situation changed. And
Sure.
now I had legitimate coverage, not a $1,500 cap. So
Yep.
it boils down to, if you think you're worth it, then live your life. It
Yeah.
doesn't, the diagnosis doesn't define you, just as anything else in your life, your sexuality, your gender, your race, your age. Do they contribute to who you are and your lived experience? Most certainly. Should you embrace all of those things? Most certainly. But don't let a single thing define your life. And
Yeah.
that goes for an HIV diagnosis.
Yeah.
And
And
and here's the Italian, and I'm sorry, but and if somebody has a problem with your HIV status,
exactly. Yep. And for those of you that don't know, that's the Italian salute. Um, but
I
I think
watered it down too, Matt.
yeah, I saw that. I think one of the keys though too, as you referenced, is that you were working for an organization that was out to assist others. That's become your life's work, but it's so vital for patients to recognize that there are groups out there that are there to support them. As you noted, the AIDS Drug Assistance Program, obviously ADAP doing a lot of work to right the ship, so to speak, and keep or get 340B, then that program rearranged in a way that focuses on getting the dollars to the right people and not an income stream for health systems.
Mm-hmm.
There's rabbit holes we could go down left and right on that discussion alone, but the fact that there are advocacy groups out there, there are people like yourself that want to help, that want people to come to them and to hear what you've just said with regards to live your life. It's okay. Yes, you're going to probably have to, of course, mourn what's happened. That's okay. But
Absolutely.
you have to keep living. And there are folks out there that are there to help you. I think even people in the advocacy world don't quite understand how impactful and pivotal the HIV/AIDS community is to all of advocacy. Would
It
you
really
mind?
became advocacy in the 80s.
Yeah, would you mind giving our audience a bit of an overview on how this all started, potentially with even ACT UP and moving into today, where now we have, I think by last count, over 20,000 disease state advocacy organizations helping patients.
Listen, for those who are old enough to remember, it was in a very dark time in this country when AIDS reared its ugly head. And
Mm,
for the younger generations who don't know about it, maybe read about it, or have some general vague idea, um, it came out of nowhere in the sense that, okay, we hear some story about a patient dying of some rare cancer,
yeah,
and it's okay, well, there's a couple, and then the fact that at first it's showing up in only gay men in big cities. Well, this is the early 80s.
yep,
Different time. Kids
yeah,
weren't coming out as gay in 9 years old in school.
yeah, yeah.
They weren't coming out at 39 years old when they were adults.
There
It
was
was a
no social media back then either.
medium back then. There was very little behavioral health and mental health programs designed for people, coping with trauma. And I say trauma because if you ask anyone about their coming out as a gay person, it's
Hmm.
traumatic because of the
Sure.
societal pressures on it. So here you have this disease, and nothing worked, right? So these people, these poor patients, were literally suffering, and the stigma that was fueling it. There are stories of hospitals where nurses wouldn't even provide care because they didn't know, am I going to get this?
Wow. Yeah.
One of our board members, ADAP Advocacy, one of the organizations I represent, one of our board members, Wanda Brendel Mouse, she's a retired nurse. She tells stories. She was one of the nurses who was like, wait, I swore an oath.
Hmm.
I have to take care of these patients. But
Sure.
coworkers weren't doing that. So it was a very dark time. And to have the advent of retro, well, let me stop. Our advocacy movement came from the bottom up, and it came from the bottom up fueled by anger.
Mm.
Anger at a society and a government and a system that was failing them. And you could go online and read stories about people who literally went to funerals almost every week of their friends, their neighbors.
Sure.
And ACT UP literally shut government offices down. They shut manufacturer offices down. They shut streets down. They were political activists. They were society activists, and they forced the government's hand. They also pressured pharmaceutical manufacturers, but they enlightened the general public. The
Mm.
general public started to see, wait, that could be my brother. That could be my aunt. That could be my neighbor. could be my classmate from 20 years ago. And the mood changed, and the mood of the country largely changed with a young boy by the name of Ryan White.
Yep.
Was a school age kid in Indiana who got diagnosed with HIV through a blood transfusion and faced, the school kicked him out. There was all sorts of discrimination. They made a TV movie about it. What would we do without a TV movie? But in this case, it enlightened this country. And then fast forward with as the medical advances were happening in the advent of antiretrovirals, now you need funding. You need government funding to put these products in the hands of the people who need it most. So you had manufacturers who knew they had to work with the advocates.
Mm-hmm.
They didn't trust them. These are the people who have been railing against us for years. And then you had the advocates and the activists who knew they needed power. What more power than a pharmaceutical company? But they didn't trust them either. And it took people like Bill Arnold who brought them together and said, we're only going to get to this spot if we come together and join our forces. And it really defines modern day advocacy today. What happened in terms of the creation of the Ryan White Care Act, which is the nation's HIV care delivery system, and everything that, what the advances that happened put people in contact with care, and then all of a sudden they were healthy. They weren't getting sick. They weren't dying. They weren't costing the state millions of dollars. And it was like the light bulb went off among the politicians and the elite in Washington. Like, wait, this is a good program. This is a good way to go about doing it. But for advocates and in industry, they were like, this is how we change policy. And that's the reason, it opened the doors to patient advocacy as a field, as a passion, and as a change maker.
Sure. Tell the audience a bit about the Denver principles and where that all stemmed from.
I'm going to just narrow it down to the coined phrase that nothing about us without us.
Yeah.
How, and it is so paternalistic, the way things have often been done and are still done, where policy decisions are being made, money priorities are being made, therapeutic decisions are being made, and you're not asking the person who is the reason you all are there. You're the reason you're all having these conversations, the patient. What a novel idea to sit down and talk to patients. So that's what embodied the Denver principles was. Now we know what this condition is. We have a name for it. We know how it's spread. We know how it doesn't spread. We know there are therapeutics. All these different. We know why we need money, where we need to spend it. But these decisions cannot be made without us. We have to be at the table.
Yeah. So a lot of discussions I've had with the patient community lately have been, of course, centered around AI. And there's a lot of fear about industry and others not just implementing AI, because there's obviously some benefits to it. In some cases, it's signaling to doctors to ask further questions. Maybe they missed something. But in others, we're hearing, how do we maybe synthesize and create hypothetical patient voices and do message testing instead of going directly to patients, which can, quote unquote, be messy. We can just use AI of synthesized patient input and do it that way. What are your thoughts? Obviously, it flies right in the face of nothing about us without us. But where you see AI both as benefit and negative?
I mean, there's so many layers to that, because we're already seeing studies of where prior authorization denials are being driven by AI.
Yeah.
I mean, prior authorization denials in and of themselves are evil, in my opinion.
Yes.
Okay?
Yep. I think that should be a malpractice opportunity, so to speak, from a policy perspective, that insurance companies should be having to carry malpractice insurance. Though they say they don't practice medicine, you and I both know that denial is practicing medicine.
Yes, it is. So to then add a layer that some computer program, and I don't mean to be dismissive with AI in that way, but some computer program is, some algorithm is saying, nope, you don't need this. If that's the case, why even tell people to go to the doctor? Why even
Sure.
tell people to go, all the thing about preventive medicine? Why get your annual physical? Why?
Hmm.
Because it's going to boil down to you go to get something done and you're told, well, no, you don't need it.
Yeah.
Well, then why did I go to my doctor, right? So I think there's that level of it. And then in terms of any drug manufacturer that's looking to replace the true contact with patient, whether it's at the clinical trial stage in the early development of a drug, to the rollout of that drug, to
Hmm.
then the access points for that drug, I think they're doing themselves a disservice. If I think the front line is patients, you're going to gain more insight from a patient directly. If you want to complement it with an E, not an I,
Yeah.
that's fine. That's one of those things where you look at what are different ways you can enhance the knowledge that you are gaining.
Yeah.
Um, but I can also, Matt, push that back on patient advocates who right now are looking to AI to do a lot of their advocacy. You are doing yourself a disservice. And we talked a little bit about advocacy, patient advocacy, and the history. This is a natural progression of there was a time where advocacy was parked out in front of a federal agency with signs,
Sure.
showing up at members of Congress's offices. And if you couldn't get to Washington, D.C., then their district office. If you couldn't get to their district office, say you're in a state like Montana where the
Yeah.
district office could be 250 miles away, then you saw when they were going to be at the county fair. And you go up to them and say, Congressman Matt, this is unacceptable. I need this drug, access to this drug. That's been replaced by, let me send a tweet. Oh, I've done my
True.
part. Let me create a Facebook page, and get a bunch of supporters to like all my posts. But how many of those supporters live in your state and have
Sure.
influence over what the decisions are being made? So it's like I think our advocacy has been in some ways enhanced by social media,
Yeah.
in a lot of ways enhanced by social media, but at the same time watered down our effectiveness.
Yep.
I think it's provided a convenient way for people to say, "Oh, well, I did my part."
Sure.
Um, and even I'm hearing, like, with the mess that's happening in Florida. Florida's ADAP is once again in crisis. People are getting kicked off the program, and those people who are boots on the ground and going up to Tallahassee or trying to figure out where legislators are in their districts are saying, "We need more of you showing up." And if you go online and look at the advocacy that's being done online, the
Yeah.
Facebook, the Twitter post, the LinkedIn post, there's a lot. But if you're listening to the folks who are the boots on the ground, they're saying there's not enough bodies showing up where we need bodies to protest, to advocate, to talk, to educate.
Sure.
So, and now you have the AI element, that makes it even more, well, we can just create this AI patient talking about what they're dealing with and
Yeah.
how they can access this, and it'll replace. So I think it goes both ways. I have no problem with AI being involved in advocacy the same way I have no problem with it being involved in a drug manufacturer trying to get a better feel for how does this drug product fit in the market,
Yeah.
access. But if you're using it as the sole or primary way of educating your company on it, you're doing yourself a disservice, and you're doing a disservice to your consumer.
Completely. And I think that you bring up another interesting point, which is, does industry really know who their customer is?
Oftentimes, no.
Hmm.
Um, and at the same time, it's one of those things that for those who do understand the importance the patient advocacy voice plays in policy making decisions. Um, I'm wearing a Red Sox hat, so I'm gonna dump on my Red Sox, and maybe industry can learn a lesson from this analogy that there are few teams in Major League Baseball that have more money than the Boston Red Sox.
Yep. Just
The
the
Boston,
Yankees, I think, right?
well, it depends. The Boston Red Sox are awful this year.
Yeah.
They're awful because
Yep.
the front office, the owners are not investing where they need to invest. Drug companies, in many cases, are not investing where they need to invest. You should be spending a lot of money on your marketing, because without people taking your medication, you don't have, your sales. Without your sales, you can't do XYZ.
Yeah.
But you should take a fraction of that money. And when I say a fraction, I'm talking like a tiny fraction of that
Yep.
money, and invested in advocacy budgets because these people, me, the patient, Matt, you, the
Yep.
people are the ones who can put a policy over the finish line or bring it to a screeching halt.
Yeah.
So, and I don't think most drug manufacturers get that. I don't
Yeah.
think the C-suite levels get it. I think those below the C-suite level do get it in many
Yep.
cases, not all. And I think that problem is in large part fueled by a conversation you and I have is
Mm-hmm.
advocacy is a long-term game plan.
Yep.
No better where do you have to look than HIV advocacy. It took years to get the world, the country, the government to change. These companies are running on quarterly profit earnings.
Yeah.
You cannot, those two things do not jive. So you have to have a certain understanding of advocacy that our advocacy budget cannot be tied to earnings.
Mm.
Because if that's the case, you're going to be stuck where you are and you're going to end up with really bad federal policy with something called the IRA,
Yeah.
you know,
Yeah.
and now industry's paying for it. And guess who's next after industry pays for it? We're going to pay for it.
Yep.
We're not going to have access to the drugs that we need. There's going to be less innovation. So, I blame the IRA happening on a miscalculation by industry, and they did not invest enough money in patient advocacy voices going to Capitol Hill saying, whoa, stop.
Yeah. Yep. And in doing this research, we've seen that the typical advocacy budget is somewhere around 1% of an annual revenue, right, for our company. The marketing budget, as you referenced, is somewhere between 16 to 20%, which makes sense, right? But at what point does the industry begin to recognize that commercials on television don't do nearly what they think they do, as much as I've been hearing, this new sales funnel, so to speak, is patient to patient. And that takes advocacy to truly understand and to move a message, right? What are your thoughts on how, let's focus on the HIV/AIDS community, on how those patients approach understanding the options that are there for them and then making the right decision? I know you've done a lot of research here.
I'm going to drop a name who I know you love and admire him, Warren.
Yep. Yes.
Gates. Warren was one of the first people that I knew who went on a long-acting injectable for HIV. At the time, it was the shot, I believe it was every month when he started. At the time, I was still taking oral medication. I was taking a dinosaur regimen, okay? I was still taking Sestiva. When I tell people that I was still taking Sestiva, they're like, wait a minute, what? I'm one of those people that if a drug has a side effect,
me too.
I get it, right?
Yep.
So what I had to go through, my body had to go through to get on the right regimen, took almost 2 years.
Wow.
My first 2 years of living with HIV was just, there was one time I thought Mike Tyson was living in my gut. Just constant pain.
Sure.
One stop was stopping bone marrow production in my body.
Wow.
My regimen almost killed me. In less than 24 hours, I was burning 106 fever. It was the medication that was doing it. So when I got on the regimen that worked, that the side effects were pretty manageable, my attitude was, if it ain't broke, don't fix it.
Yep.
Fast forward now, again, this was a dinosaur regimen that I was on. Warren, who I love and admire, he's grown into a personal friend. He's on Cabenuva. Any chance he got, Brandon, look at Cabenuva. Look at an injector. No, I don't need to. So one day I'm like, you know what? I'm at my doctor's office. She brings it up. We have a conversation. I decide, sure, let me try it. Best decision I ever made. Okay. I had been seeing commercials. I had seen print ads. I'm in policy. I had read all sorts of publications about long-acting injectables and the benefits and all that stuff. It took a friend. It took a colleague to say, this is my experience with it, Brandon. I also didn't have adherence problems. I took my meds every day like clockwork, but this has changed my life. And he was right. And it's changed my life. Well, that was that patient-to-patient relationship that changed that. I've paid it forward. I have gotten 3 people to get off the oral medications with taking a long-acting injectable, taking Cabenuva, and each of them will say the same thing. Wasn't the commercial, wasn't the doctor, wasn't the print ad. It was a patient saying, "This has changed my life for the good."
Yeah. Yep. And that's so vital for folks to hear, because I know when I was going through, both getting on to opiates and then trying to get off of them, I was reaching out to as many people as I knew, not clinicians, but folks who had been in my shoes, to try to understand, what do I do to not go through ridiculous withdrawal, or what's the right medication that isn't overwhelmingly sedating, right? Patience. We all talk, right? And that's where so much value lies. And I think that the hard part, as you originally referenced, is for the C-suite of these companies to understand that there's this old school, as you referenced the word, paternalistic mentality, that almost like Steve Jobs. People don't know. We're going to tell them what they need to know.
Mm-hmm.
And that's just not the case in healthcare.
Yep.
Right. I want to get back to you and to the organizations that you're a part of. Can you tell the audience a bit about both Plus and ADAP and your focus there?
ADAP advocacy. ADAP is Age Drug Assistance Program. What I referenced earlier.
Yep.
It provides life-saving antiretroviral drugs to patients living with HIV, and other drugs to patients living with HIV who otherwise couldn't afford it. They're underinsured or have no insurance. And this program has saved literally hundreds of thousands of lives over the last several decades.
Yeah.
It is the embodiment of a way a government program should be run. It's one of the most efficient programs there is. At Rewind, almost 20 years ago, there was trouble brewing, and my late mentor saw it coming a few years before everyone else. And he had always said, and again, this is the gentleman who told me, leave your personal politics at the door.
Sure.
He had told me, if you couldn't get Republicans and Democrats to sit down and get more money for a program like ADAP, then you weren't going to get anything in HIV done.
Yeah.
It was very few bright spots of bipartisanship within HIV care delivery and HIV policy. And the program had been perpetually underfunded. And what was happening with the economic pressures, the cost of some of the newer drugs were coming and hitting the market. More people were trying to access the program. The fact that people are living longer. There were lots of things boiling all up at once. Lo and behold, waiting lists started. So here you have this whole initiative to telling people, get tested, know your status. This is when we were learning that the faster you treat HIV and the harder you hit in terms of hitting it with the antiretroviral drugs,
Yeah.
the better the long-term health. So the message our country was sending was, know your status, go get tested. Oh, you've tested positive. Get access to a medication and take them every day. By the way, we're not going to give you all the money to do it. Get in line and we'll get to you when we can. It was
Sure.
the optics were awful. And Bill felt that we needed to have an advocacy organization dedicated solely to this issue. And he came to me, and at this point I had known him several years. And I said to him, Bill, I'm not a policy wonk. I understand policy on the Ryan White Act, on ADAP, but there are people who are far smarter than me in the policy world who I think would be a better fit. And he said, no, I want a political wonk. I don't want a policy wonk. We got enough policy wonks. There aren't enough people in our world who understand the politics of public health and how to navigate.
Yeah.
So I took it on and been doing it for 20 years and love every minute of it. Met some amazing people like you. Yeah. But I've also worn many hats over the years. The other organization you referenced, which you serve on my board of directors, is an organization called Plus Inc. Mm-hmm. And it focuses on addressing health disparities in the U.S. And it goes across all chronic disease states, rare disease states, chronic health conditions. And how do we best achieve a place of health equity? Mm-hmm. Lots of time spent on social determinants of health, which now apparently our federal government doesn't think is a thing. Let's just ignore 60 years.
That's why you're at the White House today, correct?
Well, I have that up, for two reasons. And this is a message to patient advocates that advocacy can be fun.
Yeah.
I mean, right? So I have a fun background. But also in our country, what is, even in today's world, what is one of the symbols of power? The White
Mm.
House.
Yep.
I'm a patient standing at the White House. The message I'm trying to send is you as a patient have power. You have a lot of power.
Yes.
You have the power to influence decisions. And you brought up 340B earlier. ADAP
Yeah.
Advocacy has done a lot of work on 340B because 340B rebates account for over half of an ADAP budget.
Mm-hmm.
And for those folks who are listening don't know about 340B, it's a federal program. It's about 40 years old. And basically, it was a beautiful deal struck between the federal government and drug manufacturers, where the federal government said, if you want to sell your products on Medicaid drug formularies, you have to offer discounted drugs to community healthcare organizations, what we call covered entities, at a discounted price. You can keep the spread, and that spread you can use to expand services.
Mm-hmm.
Unfortunately, like most programs, it morphed into something more into a revenue stream than actually
Yeah.
providing care to patients. We can get into that conversation. But when I first, approached industry partners about this program, I said, listen, watching the 340B debate and the fight between you, the drug manufacturers, and the hospitals is like watching the front line of World War One. It's moving like 1 foot a day back and forth.
Yeah.
Nothing's happening. And the
No.
reason nothing's happening is there's no patients involved.
Yeah.
Patients don't even know what 340B is. They don't understand the value that it could bring to their lives. And they're not involved in any advocacy on it. And we took a torch and said, we're going to light this torch. Let us run with it. And the beautiful nature of it is industry said, okay, let's do it. And my argument was, I believe on 340B reform that patients and drug manufacturers probably agree at least 80% of the time.
Yeah.
Not 100%, not even close to 100%, but probably 80% or more. And one of those things that, okay, well, we disagree. But if we could get real reform done on this program, more patients are being served. You as drug manufacturers are financing this program. Your dollars are being spent the way they're supposed to, not on, a private jet or a beautiful waterfall in a hospital or, ballot initiatives in California.
For people that think he's joking, just take a look at the University of Miami health system. But keep going.
They finance their football coach through 340B
Yeah.
rates, which are supposed to increase access to care, funding things like mobile health clinics, right? And to their credit, they did, but it's also exposed one of the ugly sides of patient advocacy, because we get accused all the time of being pharma shills.
Yes.
That were bought and paid for by pharma. And to me, that gets back to a word we've mentioned a couple times here, Matt, you and I, and it is such a paternalistic view of advocacy. And
Yeah.
I've taken it a step further, and I think it's paternalistic ableism.
Yes.
You as a person living with a disability or a chronic health condition, you don't know what's best for you. I do. I know what's best for you. I'm your provider. Let me take care of you. Instead of allowing them to take care of themselves, giving them the tools to take care of themselves. So we've been very confrontational in pushing back on that. If you want to call us a pharma shill, then you're paternalistic, ableistic.
Yep. Not to mention, if that's anyone in Congress or the Senate that's saying that you're a shill for the industry, what does that mean about the donations that you take from corporations? Is it that you can't make independent decisions either? Right?
And
but it's always one way.
There has been a lot of research on people give to candidates. Mm-hmm. People give to nonprofit charities like St. Jude's or United Way. And people give to patient advocacy organizations because they align with the values, not because they're trying to buy them off. Right? Yes. There has been so much research in this space that it's really ridiculous, and I think it does a true disservice. And I will say on our 340B project, it's now in its third year. Not once has a funder, a pharmaceutical partner, said you cannot make that statement, you cannot submit that letter, you cannot make that include that paragraph in this letter.
Yes,
not once. Right? They've given us the dollars. They've given us the editorial discretion to do our advocacy. And we're back to we agree about 80% or more of the time, and they're trusting that, right?
Yep.
And it's working. So
And this is where I really want to give you your flowers. When it comes to advocacy work, and you know, if anyone's listening that's in industry that's looking for a partner organization that not just says, "Oh, we can educate patients," but can actually bring you the receipts, and has done it for decades. This is where Brandon has always outshined anybody else. As
thank you.
Brandon, as I'm sure you're aware, as we all are, there's a lot of infighting that can happen in the nonprofit world. Um, you've never shied away from including as many different types of organizations as possible in the work that you do. I mean, I remember one of the most recent ADAP fireside chats, and I want to say there was about, I don't know, somewhere around 10 to 12 different therapeutic area and professional societies in the room. Though we're talking about 340B and particularly how that impacts ADAPs and the drug assistance program, there were others in there that their lens was just 340B or just independent pharmacies, or how that matters to XYZ disease states. But it's you're leading that coalition of people without calling it a coalition that has actually moved the needle. And this is where I would implore industry that is looking for a partner on any, not just policy work, but on educational campaigns and addressing social determinants of health, as Brandon referenced earlier. This is what he does. This is what organizations that do it well look like. And I've been doing this research for almost 12 years now. I've seen good ones, I've seen poor ones. Brandon stands in a league of his own, and in the organizations and the people that are a part of his organization are second to none. You had brought up this paternalistic ableism, and I think that we can agree industry to a sense in the C-suite has that mindset on what's the value of advocacy. We can reach the patients ourselves, we can educate them ourselves, which is blinded, completely blind to the fact that they don't have the trust. What I really want to dive into is, let's go personal. How do you describe to Sebastian the work that you do?
Oh, he wants to go to my meetings all the time, right?
Well,
And
they're fun. I would I want to go to your meetings all the time.
you mentioned the fireside chat. ADAP Advocacy started hosting fireside chats, which are a small, intimate setting, deep policy dive, and it's not all HIV specific. Sometimes not everyone agrees in the room, and it's genuinely to foster dialogue on policy. And we do things like receptions and dinners, and typically there's an icebreaker. Well, Sebastian we had one in New Haven, which is where we spend our time.
Yeah.
And Sebastian came to the reception, and I think at the reception there were 50 people. And he greeted everyone at the door, brought them over to the bar, and he said, "My papa's buying everyone drinks." Brought him over to the food and explained what was. I mean, he loves it, right? So he on board meetings, this starts off a plus board meeting saying hi to everyone.
Yes.
Listen, and we were featured in a one of the Positively Aware, their annual Living with HIV awareness campaign. I'm holding him laying on the couch, and the message is, I'm a single father living with HIV, and I'm living my life. Back to what I started with, living my life. I always wanted to be a father, and when I got that diagnosis, not once did it cross my mind I can't be a father. That wasn't changing. Right. It got delayed, but it doesn't change. So, I just tell him that I spend my days trying to help people. And in large part, that's what it is. And there are very often challenges. We got egos in this space, and that's common anywhere. But, I have seen my role in this is to elevate other advocates, younger advocates. And it's I mentioned the lesson I learned from Bill Arnold: leave your personal politics at the door. The other lesson he taught me was elevate people younger below you, because we're going to need new leaders as we all age out.
Sure.
I got into this advocacy work. I was in my 20s. I can assure you I'm not in my 20s anymore. I just three last week. And I'm now that person who has to start looking at down the road of who's going to step up. And some of the most amazing people I have helped get to this, their pedestal now, where they're a voice leading the charge. Guy Anthony
Yeah.
started Black Gifted and Whole. I mean, he's family to me. I mentioned earlier Wanda Brendel Moss, though she's not younger than me. You know, she came to her very first ADAP conference. She was the first time we had an advocate from North Carolina, and she was scared. Beep. Um, and I challenged her. I said, "Speak up. Don't be bashful. Stop
Yeah.
caring what anyone says, judges you for what you say. Just be authentic." The next year, she brought 9 other advocates from North Carolina. We had 10 advocates from North Carolina. But, so it's finding those voices who can elevate themselves and put
Yeah.
the good fight in.
Yep. Now it's so vital, as you reference, and the turnover that we see in this space is unlike any other industry. So it's vital that we train up that next group.
And
I want
that's
to be.
one of the things that manufacturers have to also, as they're realigning, how they can use advocacy more
Hmm.
effectively, align with advocacy more effectively. I mentioned earlier advocacy is not based on a quarterly earning.
Hmm.
You have to have a long range plan in effect.
Yeah.
And they make mistakes. I mean, I think one of the mistakes that industry is making right now is they're giving money to national organizations to try and influence state policy. I can tell you, as someone who is a political creature by nature,
Yeah.
and I know a lot of folks who serve in state legislatures or they're the chief staff person of a legislator, they don't like it when a national organization comes knocking on the door saying, this is why you can't do what you're doing in your state. You have to have
Wow.
a
Yeah.
buy-in, whether it's you have board members who live in the state. That opens
Mm.
a door for you. If you live in the state, that opens a door for you, unless you can make that personal tie to why you as a national organization are getting meddling is the word that
Yeah.
state
Sure.
meddling in our backyard. You're doing yourself as a company a disservice. And you can look at the track record of state legislation where national organizations have tried to lead the charge. In almost every case, they fail. I'm not
Yeah.
saying always. There are wins,
Sure.
but there are far more losses than there are W's.
The wins are typically when they, yeah, right. There you go. The wins are typically when they identify that, oh, we're going about this the wrong way, and maybe we should get some regional or state groups in that might be able to lead the charge. We'll step back.
They're
Right.
better off taking those state advocacy dollars and giving them to a state grassroots organization or a
Yep.
local organizations, and they exist. And
Yep.
if somebody says they don't exist, they're being intellectually dishonest and they're being lazy. They
Yeah.
exist. You just have to find them. And if you don't know where they are, that gets to my point I said earlier about the relationships of industry and patient advocacy. It's more than a check.
Yeah.
It's the relationship. And I may come to you and say, I need data, or do you have a contact in Congressman Matt Teresco's office?
Yeah.
And vice versa. You should be able to come to me and say, Brandon, do you know of any advocacy groups in Nebraska?
Yes.
Because almost every single state, I personally know where there's an advocate or
Yeah.
an advocacy group. And there are people who know just as many, or if not more than I do. So there are so many resources that are untapped. And I think that's one of the things that we as patient advocates have to try and educate industry on too.
Yep. Now, and that's a fantastic point because as you reference these national nonprofits trying to do work locally, the same as can be said about industry trying to do the work on their own. It doesn't work. The trust isn't there. Go to groups like yours, go to the local grassroots community-based organizations. They have the trust. Allow them to utilize their trust capital. As long as you're in alignment, they will do that work. Don't try to meddle in it, right? And as you referenced, the relationships are always the biggest thing. The
Mhm.
money, and at times, yes, listen, we have to keep the lights on. We have to be able to do that work effectively, and it takes dollars to do it. But there's so much more than just the dollars. And that's why year after year in our report, it's not the best organization is the one that spends the most. It's the one that has the most transparent and partnering approach to building those relationships and working hand in hand.
Yeah.
And it will remain true in this age of AI, I think, more than ever, that people are searching for real. My final question for you, what would you go back and tell your 20-year-old self if you could?
Oh God, I would bore that 20-year-old to death. I'd be like, okay, you shouldn't have gone there. You shouldn't have done this. Have more fun doing it. And I say that, and I joked earlier, but you got to have fun, right? You
Yeah.
do things like a silly background. This work is hard.
Yeah.
It's emotional. In our HIV advocacy space, and there are others, cystic fibrosis,
Yeah.
cancer, you lose friends all the time. Just last week, I learned that a gentleman, leading advocate in the state of Tennessee for many, many decades, Larry Frampton, passed away. Wasn't related to his HIV, but died way too young. And Larry is who brought up a whole new generation of HIV advocates in Tennessee.
Sure.
ADAP Advocacy used to host an annual conference in Washington, D.C. It was your typical cookie cutter conference, keynote speakers, breakouts, all the jazz. And we did it for 10 years. And I think Larry came to 9 of the 10.
Wow.
He came as a participant. That eventually grew into he was a panelist on our discussions, to even he moderated one of them. He just was, you lose too many of your friends. And
Yeah.
it's sombering when you see colleagues get diagnosed with something, or they've got a complication and they're struggling to pay for it. Enter 340B. That's 340B is supposed to exist to help these patients, so that they don't have to expose their pride and go on GoFundMe.
Yeah.
Right. And I think it's the message to myself would be, have a little more fun doing this, because it's draining.
Yes.
Draining because you have a system that's built against you. You have powers that be who, when you do speak up, they label you based on where your funding came from. Get back to that funding piece. If pharma wasn't funding patient advocacy, there would be no patient advocacy.
There wouldn't be. Yeah.
Government's not funding it. Hospitals aren't funding it. PMMs aren't funding it. Payers, Blue Cross, Blue Shield, Cigna, they're sure as hell ain't paying it.
Nope. Yep.
And sure, there are big donors who pay for it, but they usually have their own private agenda and they fund certain things. There would be no patient advocacy.
Joe and Sue America don't have the discretionary funds at this point either. Right?
Have fun.
Have fun.
Have some fun doing it.
I love that.
I would still do this. I wouldn't change that. I fell into it by accident. It grew into it. I've been very successful doing it.
Yes.
But I would say to myself, have a little more fun.
Well, you've still got a lot more time, and that's why your meetings are so fun. And I look forward to the next one.
Absolutely.
But with that said, ladies and gentlemen, thank you for listening today. You can find more on Brandon at both plusinc.org or .com. I'm sorry.
.org.
plusinc.org, as well as ADAP Advocacy. Feel free to give him a follow the work that he does. Sign up for the ADAP newsletter, as well as a wealth of information that will help you to understand 340B and really how it's been co-opted, is I think a good word for it, to no longer be a support system for patients, but be a revenue generator for health systems. Brandon and I will do a whole nother discussion on that one alone.
Let's do it.
And I know at ADAP's website, there have been webinars that I've had the privilege of being a part of that you can check out there on 340B. But Brandon, I really appreciate your time today and look forward to seeing you soon.
Matt, I don't know how an hour goes by so fast, but when I talk, that's usually how it goes.
Always. Pleasure. Thank you, sir. Bye.